NACD guideline that within run variability, when you run several times, it should be less, the CV should be less than 5%, and between run variability should be less than 10%. And why is this emphasized? We say the most useful utility of tumor markers is in treatment monitoring. You are going to measure these assays several times, and you can see it has increased. Yeah. And to 9 it has decreased. Yeah. So as much as possible, okay, that is I'm sure it's number one, but they take elevation as an in the elevation of patient. If however the elevation is because of variability in the analysis, the clinician doesn't know that. Yeah, the clinician knows that. And they will institute measures to either maybe change therapy, increase dose, but they will take action on elevated or a declining result. They will say that we are doing well. So it shouldn't be that it is because things are happening in the not in the patient. So and we have to always check using our IQC and EQA to ensure that we are within these specifications for precision. Yeah. Then we also need to know the known causes of error in immunoassays and look out for them because they have very high marker values like hepatoblastoma, even trophoblastic disease, gestational trophoblastic disease. ACG levels are very high. Then you can have a hook effect, so that now it just dipples down. And if one is not aware of that, then you can give erroneously low results, which may suggest that the patient is actually improving, whereas it was just a hook effect. Yeah, so you have to be careful of that. Specimen carryover can also occur when they, if you're doing, especially for labs which do batch analysis. I think most of us, we do random access, so that it's unlikely that one patient sample will follow the other, but when there is batch analysis, that can happen. So if the sample which follows a very high result, you may have carryover. And then there is the issue of these heterophilic antibodies and anti-mouse antibodies, which can also erroneously reduce results. So you have to be aware of this, and when we are releasing results, always to check, what was the previous one, what is the clinical, and if there is no matching, then you have to check back and try and identify what is the possible cause of the error. There is the issue of reference rate-based verification. Many of us don't verify the reference rate, although most tumor markers, it is consensus reference values, but a reference rate must be verified in the standard way. And for tumor markers, most of the time, the population reference rate will be used at the time of diagnosis. But after treatment, then the patient's baseline becomes their reference point, so that it is what is happening around this baseline. Is it increasing? Is it decreasing? Is it remaining steady? And the clinical decisions will be made depending on that. Yeah. And so this, of course, would require that the analytical performance of the test method is well in hand. Then for the serial monitoring of the patient results, there is what is referred to as the tumor marker kinetics. Yeah. So this is when you're looking for a change. What is a clinically significant change from one testing time to the next? And usually the clinician will determine how frequently they should monitor the patient. From the lab side, it's recommended that when the clinician does their usual follow-up, that is for the tumor marker to be done. So these kinetics, of course, will also depend on the analytical performance of the tumor marker in your hands and the biological variation. But what has been considered that a 25% change usually is clinically significant. And you need 3 measurements for you to calculate that 25%, so that you say there is an increase or a decrease. So anything below 25 can be because of biological variation or analytical variation. Then now there is a new platform being launched. Some of us are going to obtain it, and if we are going to apply it for tumor markers, that means we are going to change the method. There is a protocol for method change because of the issue of maintaining precision. Maintaining precision, so that, those of us who will change the method, we need to apply that protocol to ensure that that patient who is being monitored and has been monitored maybe for the last 3 years on the platform you are currently using, their management doesn't change just because you change the method. Unfortunately, most immunoassays are not harmonized. What you will get for, say, CA19-9 on the Vidas will be totally different from what you'd get if you're using maybe an Abotalinity or the Roche platform. So not informing your users about the change may harm the patient. Because suddenly now the result may either go up or down. And remember I said the clinician thinks it is the patient who has changed. They don't think that something has happened in the lab. So whenever there is a change, I remember we had a challenge in our lab at KMH when there was a new platform coming on, and there wasn't opportunity for that seamless change, so that you did parallel testing with one platform and the other, because there was a time lapse between the end of that contract and the institution of the next contract. So we were really hesitant about what was happening around that time. So for all of us, please, if it is a new method, if you're going to adopt the Vidas, please ensure that you follow the protocol for method change, including informing your clinicians and including also that in the report that you're going to give. So these are some of the tumor markers which are used for various applications, and you can see the number of tumor markers is few coming from the left going to the right, indicating that most of the clinical utilities is not fully recommended for most tumor markers. Screening, right now it is only PSA which is accepted, and even that with caveats, that there should be consenting to the patient. There are 8 caveats, so there is very little limitation in the use of tumor markers, serum tumor markers for screening. And also for hormones, because like prolactin in a patient with a prolactinoma, that is when you can say this is raised, there is a prolactin secreting tumor. Prognosis for a few markers like CEA, CA125, beta-2 microglobin in patients with multiple myeloma, there has been evidence that they could have prognostic implications, and then treatment monitoring and detecting recurrence is the most recommended utility for all the tumor markers that you are going to start doing from today when you buy that the Vidas Cube. So in conclusion, just reminding ourselves again, cancer is a global problem. There is a great of cancer, and the clinical lab plays a critical role. Tumor markers may provide minimally invasive, often cost-effective, and usually a source of oncology data, and so they can therefore be used in the continuum of cancer care. However, from our side, the laboratories must ensure quality of testing and the reporting of tumor markers. This is important for and necessary for patient safety. Thank you.
I think she deserves another round. very useful to everyone and very informative about the best practice when we're talking about tumor marker testing. I know there could be one or two questions, but I'll request that we just hold them. We'd like to have both scientific sessions follow each other, so that then after that we can have a panel, Q&A, so that we can also manage the time a little bit better. I believe that's okay for everyone. We want some democracy, so when I see a few nods, I believe that everyone is in agreement. So, to the next presenter, and this is none other than Dr. Charles Kariuki, who's a renowned cardiologist. He leads the heart clinic at the Nairobi Hospital. He is not just a cardiologist, but an interventional cardiologist, having trained in the he's also a member of Kenya Cardiac Society, fellow of the Royal College of Physicians, American College of Cardiology, and British Cardiac Intervention Society. So when we talk about interventional cardiology, this is the expert, and he has graciously joined us this morning to tell us about cardiac biomarker testing, the biomarkers that really matter, and how to really use them in terms of for diagnosis and management of the patients. So without further ado, Dr. I'd like to welcome you. Please welcome you with a round of applause. So we'll just set up the slides shortly.
Thank you for asking me just again to come and talk to you, and thank you also for attending. And I And I was going to bring this up, but also down because the ones may not come to us or come to whether it's the muscle, could be the acid. So you want to look and see whether this pain is from cardiac sources. So I'm not focused on heart. So we have biomarkers that are released in situations where you've got cell death. That's myocardial necrosis or stress, myocardial stress. And these are applied in diagnosis and risk stratification of patients with suspected acute pulmonary syndrome. We also do use them in patients with heart failure, both to make a diagnosis, to track patients, and even in other conditions like acute pulmonary embolism, where we prognosticate. So a troponin will not diagnose for you in acute prognosis. But for us in our hospital, just to digress a little bit, if you come to us and we make a diagnosis of acute pulmonary embolism, which I think everybody knows what it is, clots going to the lungs. If your troponin is negative, you can say thank God, because now you can be put on the ward. You don't have to raise your 1,000 shillings to go to it. But if it's positive, we put you in the ICU or in the ICU. That's the difference for us. So we add it on to our tests to prognosticate the patient. We categorize patients as high risk, moderate risk, low risk, based on some of these biomarkers. So the accuracy of biomarker and the turnaround time, no need waiting in casualty for 6 hours to make a decision which ward you're going to, is important, just to give you a highlight. So why do we bother with cardiac biomarkers? You get a biomarker and still constituting your patient, and then you get the result the following morning. Or if you're in an outlier town, you send it to the main hospital the next day, telling you that, oh yeah, by the way, the patient had a heart attack. But heart attack management is time sensitive. With something we call a golden hour. If you come to us early, within the first 1 hour, of a major heart attack, your mortality can be very different if we apply appropriate treatment from if we need that diagnosis 6 hours later. So in certain categories of acute coronary infarction, we have two main ones. One where we need to take you to the lab or give you the breakdown clots quickly. And believe me or not, we now have come down to saying that if you show up to a hospital with the symptoms of a heart attack, within 10 minutes, you should have received the treatment medication. That's the world standard today. Now that 10 minutes might be to argue with the cashier or to discuss with the askari about filling in a book, writing your car number and whatnot at the gate. It can also be the time it takes to even find which door you're supposed to go into. And even when you get there, there's somebody asking you about whether you have a family history of ingrowing toenails instead of focusing on the diagnosis. So the whole pathway of trying to establish whether you have myocardial injury or an acute myocardial infarction should be very short. We don't actually wait for a troponin to make a decision to treat a heart attack. If it is of category 1, elevation myocardial infarction, these are patients who come with STEMI, as we call it. Patients who come with totally occluded artery. We have ways of making our diagnosis. In that situation, the biomarker to us does not matter. We